Hello and welcome to episode 3 of the Equity Plus podcast. I'm your host, Erin Story, Director of Communications here at CareShare Health Alliance. In this episode, I'll be talking to Honey Yang Estrada, President of the North Carolina Community Health Worker Association. We'll discuss a little about her background and what brought her to CHW work, how community health workers help bridge the gap between their community members and healthcare systems, and finally, how the Community Health Worker Association truly centers equity in the support they provide their members. So, Honey, welcome to the podcast. We're so excited to have you here with us today.
Yeah, what's up, Erin? It's good to see you. I am Honey Yang Estrada, and I'm the president of the North Carolina Community Health Worker Association.
So, how did you get to where you're at today? What got you started as a community health worker?
Oh man, what a story. I have to start this story off by talking about my mom. Like many Hmong families, my family were refugees during the Vietnam War. And my mom was 13 when she came to the States. And as a child, I watched my mom, who at that time she was a Head Start teacher, and as a Head Start teacher, she knew the families, specifically the Hmong families, pretty well. And on the weekends, I'd go with her and to other families' homes, and I played with the kids. But she would sit at the table with the adults, and they'd talk through things like how to fill out Medicaid applications, and how to navigate WIC, and how to turn in your WIC vouchers, and things like providing support for when they needed to go to the doctor. So as I look back at that journey with my mom, she was the first community health worker I've ever known. And when I got my first big girl job at the local health system, I found myself very much in that role. We would have people from the community, Hmong families, friends and family members would call and ask, "Hey, I need a doctor. Like, I need a good doctor that I can see, that I would be able to trust to see me for my achy joints, or I need a referral to a surgeon. Who's good? Who do you know? Or, hey, you work at the hospital, so you know where all the resources are. Can you help me with how to get access to pay for my water bill, or where we can get access to a food pantry?" So as I look back at that journey, I was always doing some type of community health worker work without having the title of a community health worker. And the same is true with my mom. And as I look back at my journey, and I say this in a lot of spaces, community health worker is so much more than a title for us. It's who we are as people. It's the heart of our work. And was very fortunate that I became involved with state level efforts early on and continued to stay involved. And when we made the decision to formalize the association, I was very honored to step into the role of the president. So that is how I got here.
From your work as a community health worker and your work as the president of the Community Health Worker Association, how do you feel that community health workers connect community members to their healthcare systems?
Oh, that is such a great question. When I think about who community health workers are and our relationship with the community members, we serve as community health workers, we serve as liaisons, as bridges between the systems, all the systems, health, and not just the health system. I know in this context, we're talking about the health system, but all the other systems, educational systems, the social services systems. So as community health workers, because we have the trusted relationship with our community members, we can bridge that gap pretty well between community members and the systems. So I think about just my own personal background and that of community health workers that I know. And even for you, Erin, like, you think about it, you're much more willing to do something with a person you trust, right? To take the advice of a person you trust as opposed to somebody else that you may or may not know. And so for a community members, the average community members, I think this is really where CHWs shine, is the different cultural nuances. I think about just even in my own family with my grandmother and conversations that we've had to navigate through, where she's got a little bit of a distrust with Western American medicine because that's not her culture. So it's helping to break down those barriers to see how we can work together collaboratively to get to that end result, which is, of course, healthy and positive outcomes. So community health workers, man, community health workers can make magic happen in communities. And it's because of that trusted relationship that we have with the community members we live and work with every day that really gives us an insight. And I think the shared lived experience too. We talk about lived experience as something that is so important and critical for us as CHWs. We share that with the community members we live with. We know what that struggle looks like. We know what it feels like to be looked down upon or to not understand something. So when I'm talking with a community health worker, I know that I can trust this person. And not only can I trust this person understands me and sees me. And I think that's what makes us so special in working with navigating the healthcare system.
Do you have an example or a story you'd like to share about a community health worker bridging the gap between the healthcare system and a community member?
So many examples. One that comes up to my mind immediately is this happened during the pandemic. One of the CHWs who was on my team, she was working Spanish-speaking CHW. She was working with another Spanish-speaking community member, and he was having some trouble at the local FQHC. And there was just a lack of understanding, and we couldn't really. He was talking about all of the trouble that he was having with scheduling an appointment and getting his medicine. We couldn't figure it out. So what she did was she said, let me make this phone call with you. Let me come over. So she went, she was at his house and she called the office with him. And it turned out that he actually had a small balance on his account, but he didn't understand that they really needed to get that balance paid. He was just trying to schedule an appointment, and the office was trying to collect his payment. And he didn't understand what's going on. So there was a breakdown in communication. And so the CHW stepped in, and the balance was, I think it was significant enough to where he needed some support. So she navigated that entire process for him. She navigated and helped him get support to be able to pay that balance off. And then they were able to get an appointment scheduled for him so that there wasn't a lapse in coverage or a lapse in care. And he was able to get in to see the physician and get his meds. So when you talk about bridging the gaps, because had that CHW not been there, who knows what would have happened. And that's just one example of so many different stories. We can go all day talking about stories just like that one.
Yeah, I imagine that. Oh, yeah, that really speaks to my heart too, to have a Spanish-speaking patient at a FQHC, because that's where I worked and did some interpretation work. Just hearing that it's so awesome to have somebody that is, I don't know, it's almost like a support system for you to get through the medical system.
Exactly. Somebody I was talking with once said it's almost like having somebody there to hold your hand through the whole process, and that's what CHWs do. We hold hands, and because they trust us, because those community members trust us enough to hold our hands, to provide that support and guide them through all of that. So yeah, oh my goodness, you talk about bridging gaps. That's our bread and butter.
It seems that community health workers are especially helpful when it comes to the social drivers of health. How would you say that community health workers can help healthcare providers understand how the social drivers of health apply to their patients and their care plans?
That's an excellent question, Erin. I have been guilty of this. I will tell you, when I used to work at an infectious disease clinic, and so as the healthcare team, we're always so quick to make judgments about when patients miss appointments or when they don't follow through on specific instruction. And then we're quick to label these patients as non-compliant. And there's so much more to it, because in a healthcare setting, you only see what you can see within the four walls of that clinic. There's so much more to it. I'm guilty of this, right? I'm guilty of this because I worked in a health system for many years. So I know what that looks like, and very guilty of that, and own up to that. What we fail to see is that when we look outside of the four walls of that clinic, there are so many things outside of that clinic that impact our health. And this is really where community health workers brings so much value to the healthcare team, because while that healthcare team can only see what's inside those four walls of the clinic, the community health worker has access to that community member's home. Again, because we have trusted relationships. I say this in different settings. We get the invitations to the birthday parties. We get the invitation to the dinner table. So we get to see things that a physician, a nurse, anybody within that healthcare team within a clinic will never see. So when we talk about social drivers of health, we get to see, okay, inside of this patient's home, they have black mold growing on the walls, or they don't have any food. They don't have clean water. Well, no wonder they're not coming to their appointment, because they're focused on trying to keep their family warm for the next day, or trying to get their family fed. They're not thinking about, oh, I need to take my hypertension medicine, or I need to make sure that I get my insulin for my diabetes. I'm not even thinking about that, because the need right now is I need to keep my family fed and I need to keep them warm. It goes to, when we give instructions from the healthcare setting, like, oh, eat healthy and go outside and go for a walk. What we don't see is that this community member, this patient, lives in a food desert. And the closest grocery store, oh my goodness, is miles away. They don't have access to fresh fruits and veggies. And this person might live in an unsafe area and cannot go outside to take a walk because it's an unsafe area, or it's surrounded by 4-lane highways, but yet we just expect this person to be able to do all of the things that we're instructing this person to do. So when we look at things like social drivers of health and how that impacts a person's health, looking at whole person health, there is so much to consider, so much to think about how that impacts a person's overall health, and who best to address these things than a CHW who can see all of the challenges that the person might be facing, bringing that back to the healthcare team to say, this is what I'm seeing. Let's talk about how we can address these social drivers of health before we can get to the healthcare nitty-gritty pieces that we really want to get to. There are, again, so many examples. This is a CHW from North Carolina who works in the healthcare system. And what they were finding was that the clinical team, the healthcare team, could not understand what was going on, because the patient's numbers, it's a diabetic patient, the numbers weren't adding up. The math was not mathing. And they couldn't figure out why, because the patient is reporting, I'm doing everything you're telling me to do. I'm taking it the way you're telling me to. I've done all of these things. And so the community health worker stepped in and did a little home visit with the patient and sat down with the patient and said, show me how you're doing this. What does your process look like? Walk me through it. So the patient walked the CHW through it. And what the CHW found was that the patient was not doing the math correctly. Right? Ding, ding, ding. There's our answer. Well, no wonder the math wasn't mathing. The math for real wasn't mathing, because the patient was doing the math wrong. And so no wonder her numbers were being impacted. So it was a teachable moment. And he got on the phone with the nurse and said, okay, walk me through this. I think we've realized what's going on here. And so they were able to provide some intervention and address the situation and what was going on there. And that was very simple. That was just, a CHW saying, let me take a look at this and show me how you're doing this. Walk me through your process. Help me to understand it. But we would never have known, they would never have known that had that CHW not intervened and stepped in.
From that example, it seems almost like the CHW is a liaison to talk to the provider, because sometimes speaking to a nurse or a doctor or mid-level provider can be kind of intimidating to patients.
Yeah, no, and you bring up a great point, because in this story, both the CHW and the patient are both African American. And I know for us in the Hmong community, we hold physicians and nurses in high esteem. We see them as authority figures almost. And so there's a level of respect. And you're absolutely right. It can be intimidating because we don't want to upset them. We want to show that we're doing a good job, that we're taking our medicine and, that we're doing all of the things. So it might be a little bit intimidating to tell the truth, but I'm not going to have a problem telling the CHW the truth because, well, the CHW is just like me. And so she gets me, right? She gets me. I understand her. She gets me. And so, yes, absolutely. CHWs can definitely bridge gaps because they are that go-between. They are that liaison. They are the bridge to making sure that we can connect social drivers and healthcare all together.
Okay, so my next question was around the North Carolina Community Health Worker Association and how did it develop? And I know that you said you had kind of been there from the very beginning. How did your relationship with it develop as well?
CHWs have been doing work in communities for decades, right? Years and years and years. But for North Carolina specifically, our journey started in 2014. And at that time, there was a community health worker coordinator inside the Department of Health and Human Services at the Office of Rural Health. And she was traveling across the state to find out what CHWs needed in terms of training and certification in a formal network. And those listening sessions went on for, I believe, a couple of years. I went to my listening session. The listening session that I went to was in 2015 or 2016. She came to a neighboring county. My sister-in-law actually sent me the flyer and was like, here, I think you need to go to this. This sounds like stuff that you do. So I went, and I remember sitting in that room and talking with other CHWs about what we do, what our roles are, and talking about what training could look like, what certification could look like. So that was like, again, 2015 or 2016. And I continued to stay involved as we continued to gather CHWs to talk about what this could potentially look like. Between 2014 and 2017, that information was gathered, and a recommendations report, the 2018 recommendations report, was published. That's available on our website. I know that it's also available on the Office of Rural Health's website. And that really laid the framework, some foundational framework for what the future of CHWs could look like. There were 2 CHWs who developed our standardized core competency training. That curriculum is being taught in our community colleges today. We started with 6. We now have 13. We're getting ready to have 14 community colleges that teach the curriculum. And in 2020, during the pandemic, we saw the real need, right, for community health workers. There was a huge spotlight shone on community health workers and the magic that they can work inside of communities. As we looked at that, at that time, this group of community health workers was formed. I missed this part, but in 2019, the Community Health Worker Advisory Committee was formed. It was just a bunch of CHWs from across the state, and I was asked to chair that committee. I very reluctantly said yes. I was scared to death. So I chaired the committee, and we continue to have conversations about the need for what training and certification could look like. Did we want training and certification? What does this formal network look like? And through the pandemic, saw the need to really bring the workforce together. We formalized the association in 2021. We are a nonprofit. And in late 2021, we pushed forward with applying for a grant through the CDC alongside of several state partners. And those dollars are what came to jumpstart and launch the association. So through those dollars, we were able to secure personnel and resources to develop our framework for training and certification. So we are very excited today we're very proud that we've got the curriculum that's being taught at the community colleges. 2 of those colleges teach the curriculum. It's bilingual, so it's English and Spanish. Very proud of that. And it's been just a little bit over a year, but now we have 800 plus certified community health workers across the state of North Carolina. So shout out to all of the community health workers out there who are doing work inside of communities. We're so pumped and proud of the work that it has been accomplished, and we're just getting started. So there's so much more to come.
I know that when you were developing the training and certifications, you really put a lot of effort into making it equitable. Do you want to talk a little bit about that, some ways that this training is specifically made to be equitable towards CHWs?
We really try to operationalize equity in every facet of our work. So when we think through what that looks like, it was really important to us that our curriculum was accessible. The way that we operationalized and delivered everything was fueled by CHW voices. Everything that we have done has been CHW led and CHW launched. In CHW culture, we say nothing about us without us. That means that we are leading efforts. It is for CHWs by CHWs. So as we looked at the curriculum, we had some really intentional conversations with the community colleges at first. Our curriculum is delivered through the continuing education and workforce development side of the college. We don't ask for a high school diploma or anything like that, because again, we understand that we need to remove barriers for CHWs in order to access it. And the curriculum, talking about leveraging a pandemic, it was designed to be delivered in person. But I think what the pandemic taught us was that we really can do this virtually, and we can do it well. The majority of the classes are virtual. There are a few that are hybrid, and there have been instances where some small organizations have asked if they can bring their CHWs and have a class just for them in person. And so we really leave that up to that instructor to make that decision, because what we understand, all of the communities are different, right? So what happens in the East is certainly not what happens in the West. So really giving those instructors flexibility and autonomy in how they want to lead the class. All of our instructors, we do encourage them to be CHWs themselves. When we started all of this, looking at those minimum requirements for CHW instructors, we want them to have community-based experience. And so as they're, again, nothing about us without us, it's really important that the CHW instructors are individuals who understand what that community level work looks like, what that feels like, how it smells. All of those components really impact learning. So we've worked really hard with the instructors to make sure that they understand that. And as we look at, again, accessibility, we have really intentional conversations with the colleges. As a matter of fact, I just had one just a couple of weeks ago with another college to say, some of these CHWs, this is going to be like the first time they're going to get a computer, and they might not know how to send an email. They might not know how to navigate Microsoft Office. What resources do you have in place to support CHWs who are new to this? So some very intentional conversations to ensure, again, that we can meet people where they are. That's only the curriculum side of training. Also with training, a lot of our training modules, we've partnered with North Carolina AHEC and have been, again, very intentional to ensure that we operationalize language access. And so some of not all, but a lot of those trainings have been translated to Spanish to ensure that we can reach our monolingual, bilingual speaking communities, those community health workers who come from those communities, so that, again, they can have access to those resources. And all of that leads to certification. And certification is not required. It's not mandatory. It is an option. It is available for CHWs who choose to pursue certification. And what we hear from CHWs is that certification gives them a sense of belonging. It gives them a sense of camaraderie. It gives them a sense of, I did something that I'm proud of. And so we love that, the pride that we see in CHW's faces when they get their certification documents. So yes, we have training that leads to certification. Of course, that is wrapping up and completing the training through the curriculum at 80%, submitting that document or those documents up to us. It's a certificate of completion. There's not a state administered test because we didn't want to teach to a test. We believed that if we taught the curriculum to a test, we would lose the essence of who community health workers are. So we chose not to do that, again, very intentionally. We also have our legacy track of certification, and that's something that I'm very proud of because this honors CHWs for their lived experience. And legacy track, the requirements for that are 2,000 hours, which is an equivalent of 5 years of experience. That's paid or unpaid. So we have CHWs who've been doing work in communities, again, for decades and decades and decades. Let's honor those CHWs for the work that they're doing. So it's 2,000 hours of experience. It's knowledge of at least one population group. So for me, I am Hmong American. I have strong knowledge of the Hmong population. That's knowledge of one population group. And then letters of references. And those letters of references can come from a number of people. It could come from a community member that CHW has worked with, or a community partner that can attest to the work of that community health worker. So again, looking at equitable ways of how we can meet CHWs where they are. Oh, and this is my favorite part too, is when we talk about specifically for certification. Once upon a time, I thought I wanted to be a nurse, and I'm a terrible test taker, and so I didn't make it. I didn't make it through nursing school because I'm a terrible test taker. And so knowing again that we have CHWs who maybe writing isn't their best strength, and that's okay. So let's set up alternate ways for them to get those applications submitted for certification if that's what they want. So our team is prepared to provide supports in, like, let's set up an interview. We can have you complete your application through an interview process. Just set it up through Zoom, or do we need to have a chat on the phone? So we're really trying to be cognizant of the fact that CHWs are going to have different needs. Not everybody's going to have their writing strength. So let's think about how we can meet CHWs where there are, so that we really can be equitable in this process.
Another thing that seemed to come up while we're talking is that sense of belonging for community health workers, what they have when they receive their certification and at the Community Health Worker Association. Do you feel like before the association, this work was more isolated or siloed, and now you're able to grow the role of CHWs professionally through having a space for collaboration?
Yeah, absolutely. 100%. I think you've nailed it. So community health worker is an umbrella term, right? So it's an umbrella term, and we're working really hard to make that a little bit more uniformed, because under the community health worker umbrella, there are all of these different titles. So again, this is why I didn't realize I was a community health worker for a long time, and was doing community health worker work long before I realized, hey, that's me. I'm a community health worker. So we see lots of different titles, like patient family liaison, or community outreach educator. So there's all of these different titles, and there's so many, there's hundreds of titles. If you look at the job description, if you look at the role, you're going to know, oh my goodness, that's a community health worker. And what we saw even early on in 2015, when I got involved, is there's all of these people just like me who are doing work in community just like me. And yet there's no sense of camaraderie, because for a lot of community health workers, a lot of our work is grant funded, right? Good, bad, and different, it is what it is. So there are philanthropy dollars, and we get lots of funding and to do a project, and we get a community health worker in there, and we carry out the deliverables for the funder. But then those dollars come to an end, and the grant ends, and then that community health worker goes right back to what they were doing before, or we find something else. And what we needed was a way to bring the workforce together, to build momentum, to build power, because community health workers, the majority of community health workers are women of color. women of color who come from disparaged communities, women of color who understand the struggle and who know how to navigate the system because they've been in the struggle themselves, right? I know what it's like to be on Medicaid. I know what it's like to be looked at, to be looked down upon because I'm showing up at the time it was BI-LO, the grocery store, because I'm showing up at the grocery store and I'm turning in my WIC vouchers and the cashiers are looking at me kind of funny. Like, I know the shame and embarrassment I felt. And I know that when I'm working with community members, I want them to understand, I know what that feels like. And for a lot of CHWs, we've never had a professional home before. We've never had an entity to call ours. And so with us building and formalizing the association, it was an opportunity to bring these people together to say, and I heard this during our first North Carolina CHW summit, which was a couple of years ago. There was such a positive buzz. And this was a virtual summit. This wasn't even in person because 2 years ago we weren't meeting in person. So during our first summit, I heard all of these, people putting into the chat in the comments of, oh my goodness, I am with my people. These are my people. I didn't know that there were people who are out there doing work just like me. And for a lot of CHWs, being part of a professional association is new. So a lot of CHWs don't really understand what does that mean to be part of an association? What are those benefits to me? What does that mean for me as an individual? And what does that mean for me as a professional in my career and my professional growth and development? So really, as we look at building and engaging the workforce, that's what we want to do. Is, of course, we want to engage and we want to build leadership and professional pathways for CHWs so that there is a path and it's recognized not just by CHWs themselves, but by their communities and by other health disciplines and professionals.
Can you tell me a little bit about the different levels for community health worker certification and how they're informed by the socio-ecological model?
Yes, we're very excited about that. A huge shout out to our friends at CHASM, Rumana and Abdullah. So what we did with that is there is literature, and this is credit to Abdullah's work with the violence prevention model. But if you look at public health framework and the socio-ecological model, we understand that CHWs do work all up and down and across that socio-ecological model. So as we look at building professional pathways, this was a way for us to honor the work that CHWs are already doing in communities. So when we look at the socio-ecological model, the way we model this, and this goes back all the way back to, I remember during the first listening session that I was a part of, when we were talking about certification, I remember saying the CHES certification, right? The Certified Health Education Specialist certification. And I remember saying in that listening session, why can't we have different levels? Because like CHES has 2 levels. So if we build a certification for CHWs, why can't we have different levels? And the way that we decided to tackle this was to build in public health framework, because the APHA definition is that CHWs are frontline public health workers. So if we take a look at that public health framework of the socio-ecological model, from the individual level, all the way up to that executive policy level, that's what we modeled our advanced levels of certification after. So we're going to be launching in August next month our advanced levels of certification. And that gives us an opportunity to recognize CHWs and give them certification at 4 different levels, from the individual level to the community level to the organizational level, and then all the way up to the executive policy level. So what does that look like for CHWs? That is at a level 1, that individual, interpersonal, intrapersonal level. Maybe we have a community health worker who is doing that one-on-one work, taking care of my clients, taking care of my community members, making sure that we're taking care of that one person. It's one-on-one, all up to a community level where now we've got CHWs who are doing work within the community, providing community education, not just one person, but a group of people. To the organizational level where now perhaps I am in a supervisory advisory role at an organization, and I have a team of CHWs, and I am providing not just leadership for those CHWs, but also advocating to the organization on behalf of my CHWs, my team of CHWs, what we need, all the way up to that executive policy level, where now we have CHWs doing work at a policy level, that macro level, working to impact policies and how that impacts all the way down to the individual level. So that is how we have decided to push forward with our different our advanced levels of certification. Again, remembering that we have CHWs who are already working at these different levels. I am a CHW. If I were to apply for certification, I would apply for a level 4 because I am a CHW at a level 4 doing executive policy level work. So we have opportunities for CHWs to be honored for what they're doing. And it also gives CHWs opportunities to grow. And, we've already received interest from some health systems who want to model their CHW as the structure for their CHWs after our advanced levels of certification. So this is exactly what we're hoping to achieve with this, is really, again, being equitable in how CHWs are treated and how they are honored for their work, the work that they're already doing.
Honey, thank you so much for taking the time to be with us today and for such an interesting conversation. Are there any final thoughts you'd like to leave us with?
I think right now, especially as we think about CHWs, it's the push for sustainable funding. And this is something that not just North Carolina is facing, but nationwide. I think right now, what I continue to hear from the workforce is that there are so many people and organizations who lump us into everything that happened during the pandemic. And now that the pandemic is on its way out the door, it's like, okay, well, we don't need CHWs anymore. But we were doing work before the pandemic, and we're going to continue doing work long after the pandemic. And right now, as we look at sustainable funding for CHWs, the struggle and the challenges that we continue to face as a workforce, the advocacy here is real, and it is happening at all different states across the country. And so CHWs, if you're out there and you're listening, we have got your back, and organizations and allies, if you're listening, join us in advocating for sustainable funding for community health workers.
Thank you for listening to the latest episode of the Equity Plus podcast. And special thanks again to our guest, Honey Yang Estrada, for helping us shine a light on the vital role that community health workers play as part of our healthcare system here in North Carolina. If you like today's podcast, be sure to subscribe to hear more. To learn more about CareShare Health Alliance, visit us at caresharehealth.org, and don't forget to check out our hub for community-based organizations working to promote health equity and community voice, the Equity Plus Network, at equitypn.org. That is EQUITYPN.org. We can't wait to connect with you there.